recorded, please exit the call right now. As always, we welcome suggestions for future topics, and you can submit those again to the RA ASAM email account, which is posted right here on the slide. We are always wondering and welcoming ideas for future topics, so please don't hesitate to submit those. A couple disclaimers going into the presentation today. So just want to make sure everybody understands that ASAM alignment is required of drug and alcohol treatment providers that receive federal or state funding for the treatments or for providing treatment services under agreements with single county authorities and managed care organizations. So we've had a couple questions about that more recently about, is ASAM alignment, is that just a recommendation or is this a requirement? And ASAM alignment is a requirement for any entities or providers that are receiving state and federal funding. And obviously, if you have questions about that, please don't hesitate to reach out to the RA ASAM email account. We're happy to clarify or to answer any questions about that. So just wanted to make that very clear. And I also just wanted to make sure people understood that the information presented today provides an overview and a summary on the topic of therapies. It is so extremely important for folks to review the entire ASAM criteria text in its entirety. Obviously, it's important to attend the ASAM trainings that are available and reviewing other resources available through the DDAP website. I think it's very kind of easy to kind of take fragments of the ASAM criteria and to view them independently, but we really don't understand the full spirit of the ASAM and intent of the ASAM criteria unless we really look at all the various elements. And I'm going to be bringing this up a couple times today during our presentation. So I just wanted to make sure that everybody really understood that. If you have questions about how to access the DDAP trainings, those are available. Also, the links for those trainings are on the ASAM alignment website, and we can put the link for that website in the chat as well. I am at this time going to turn it over to Rebecca Sedlock.
Great, thank you, Kathleen. And so everyone can see that we have 4 learning objectives for today. The first is that we're going to have an improved understanding of the therapies that should be offered at the various levels of care. Also, everyone on the call will know where to find additional information in the ASAM text related to therapies. A lot of the slides have the ASAM page numbers where you can find it, so that should assist you if you have additional questions or aren't sure where some of this information is coming from. The attendees will understand the difference between program-driven and individualized treatment, and also everyone on the call will understand several key definitions related to the topic of therapies. So we can go to the next slide, please. And so we're going to start off today with looking at program-driven versus individualized treatment and talk a little bit more about what that means. And you can see that we've got the 2 pages for reference for both program-driven and individualized treatment for the ASAM text. And so when we're looking at program-driven, a lot of times programs are founded on the length of stay that people are expected to attend to complete that program. And when we're looking at the ASAM spirit, we're looking for what does that individual need at this point in their life in order to succeed in their recovery journey. And so with the ASAM implementation, people can successfully complete in 2 weeks, but they also may need 4 months at that level of care. And so when we're looking at what we want to do is look at that progress that that person's making and then determining what they need based off of that progress. So that also ensures that the correct level of care is being received. At times, an individual might need to go to a higher level of care for a week or 2 for stabilizations or medications or even stabilization in their current environment. And so the individualized treatment will look at the person as a whole and how to best meet those needs. Although levels of care might be considered program-driven, the treatment a person receives inside that level of care requires individualization. This means that not every person who is involved in the level of care attends all of the same treatment groups. So if someone's in an IOP program, they may attend a relapse prevention group. They may have a mental health co-occurring group, potentially a trauma group. They may address any childcare or unstable housing, legal issues, maybe another group. And the treatment protocol needs to address all of those domains that a person is assessed to need. And that could be either done on site at that location. You could have a memorandum of understanding with another agency, or the single county authority or SCA can help address some of these needs. Okay, we can go to the next slide. And so when we're looking at a program-driven schedule versus a patient-driven schedule, what we're looking at are the okay, this is what the program looks like. So we have groups being offered at this time during the day. And what we would expect to see in the patient-driven schedule is that the two counselors that maybe are offering groups at the same time are not offering the exact same group for everybody in treatment. And so someone could have, if you look at that patient-driven schedule, you can have one counselor running one of the groups listed and the second counselor running the other group that's listed. When we're looking at a program-driven schedule, in the past, there really weren't a lot of opportunities for mutual support groups. And so people either attended AA or NA, and those were their only options. But now with the expansion of the understanding that not everyone is appropriate to attend an AA or an NA meeting, there's lots of other mutual support groups that are available. Some are specific to the substance that someone's using. There's a medication-assisted recovery anonymous group, but there's also something like Smart Recovery or another form that a person could attend to get that mutual support without actually attending an AA or an NA meeting, if that's not appropriate for those individuals. In a program-driven schedule, we're looking at, there's not really a lot of opportunities for people to meet on an individual basis. Lots of times program-driven schedules rely heavily on group therapy or other group activities. And so when we're looking at a patient-driven schedule, we recognize that group therapy and group activities are important, but there's also sometimes things that someone may need to meet individually with multiple times a week, or at least every week, or various times. So making sure that that opportunity is available for everyone as they need it as well. Sometimes, too, program-driven schedules only offer one type of evidence-based therapeutic techniques. And so if we go back up to the first point on this chart, looking at everybody offering the same group at the exact same time with the same topics, versus looking at maybe this group is appropriate for this individual, but another group is appropriate for another individual, but they're all in the IOP program. And so looking at how to find that balance of what specifically that individual needs and how your agency can best meet those needs. Also, in a program-driven schedule, there's usually a rigid uniform schedule that all patients might attend. So we may say, this person, we have group therapy every Monday, Wednesday, and Friday from this time to this time, and every Tuesday and Thursday from this time to this time. And that is when everyone is expected to be in treatment or in group, rather than looking at, okay, we have maybe I don't know, 5 or 6 groups a day. And so if this person's enrolled in this program, they're expected to attend one group a day, maybe letting them pick which group it is that they attend based off of the schedule that they have as well. Also looking at abstinence-only based philosophy, a lot of programs are enforcing abstinence-based programming and only allow people to enter treatment if they agree to abstinence. And so when we're looking at the patient-driven schedule, it's really looking at what are some other options that this person could have. And so what are we considering abstinence versus what are we considering recovery, and what's going to help that person achieve that goal of long-standing recovery. And so if it is maybe a harm reduction approach where we're looking at how a person can maybe reduce the amount that they're using, or maybe make an agreement with them that they can only use during certain times of the day, and then processing through what that looks like might be more successful in engaging that person, but keeping them in as part of their recovery as well. Okay, next slide, please. And so when we're looking at the therapies overview and we're looking at that individualized treatment, we look at the person that's sitting in front of us to prioritize their needs. Current substances are much more potent than they were in the past, which leads to a more altered brain chemistry. So some substances can cause irreversible damages to that person's brain. And so as a result, people might have some difficulty answering questions, and they can give signals that they're not being honest when in actuality, the individual is not able to recall that information. And so as a result, some assessment questions might need to be restructured based on the language used in that assessment, especially if the language is confusing or words being used are unfamiliar to the individual answering those questions. And motivational interviewing techniques help individuals arrive at the decisions themselves to enter treatment rather than being told they need treatment. When individuals are able to identify what changes are needed and why, they are more likely to engage and remain engaged in treatment. Next slide, please. And so you can see that there's definitions of the types of treatment services or therapeutic activities. It's not everything here listed as a treatment service, but it is a therapeutic activity, and also the people who are able to provide some of those activities are listed here for your reference. And Kathleen is going to go ahead on the next slide and show you grids illustrating the types of therapies that ASAM lists under each level of care. She wanted to point out several terms noted in each level of care that has definitions listed in the back of the text, and the definitions are listed on the slide. So if you've not had a chance to look at Appendix C yet in the text, I would strongly encourage you to do so. In addition to the definitions I have on this slide, there are other definitions that offer a lot of clarification and explanation that I think are critical to our understanding of the ASAM criteria across all levels of care. Kathleen, I'm going to turn it over to you.
Thank you. All right. Yes, I just like Rebecca said, I cannot stress enough the Appendix C in the back of the text. The definitions include a lot of very, very helpful clarifying information. So again, if you haven't had an opportunity to take a look at those definitions, I would really encourage you to do so. So this slide right here, I know there's a lot on it, and if you can just kind of bear with me here while I walk you through this, I think this will be really, really helpful. And also before we kind of dig into this, I just want to remind folks today that we're talking about therapies, right? So we're talking about one component of ASAM implementation. We're not talking specifically about staffing or support systems or documentation today. Those things may come up when I'm discussing these things, but again, it's really important when understanding the spirit of the ASAM criteria to look at everything in context. But we're talking about one component today. We're talking about the therapies. So I want to point out is that on this slide here, on the first column where it says clinical services and therapies, so everything listed in this column comes directly from the ASAM text and the therapy section in each level of care. So when you go into the ASAM text, and I'm sure a lot of you are familiar with this, when you go to a specific level of care, there's going to be a section titled therapies, and it's going to list all the therapies that should be provided at this specific level of care. So this column, clinical services and therapies, we literally went through the ASAM text and we listed out really everything that we saw across the levels of care. And then the QI team put together a really nice grid kind of illustrating the therapies that should be offered for specific levels of care. A few minutes ago, we just discussed the difference between program-driven and patient-driven schedules. And when looking at these therapies grid, I want to remind folks that patient schedules should be driven by their multidimensional assessment and their treatment plans. Obviously, patient choice and preference and culture and gender identity and many other factors we need to be mindful of these things when we're deciding what goes into a patient schedule. Patient schedules should look different for everyone. The point of showing you this grid in its entirety, we're going to break this grid kind of out with outpatient and inpatient in a minute here, is to show you that it's not really so programs can develop schedules that include one session of each of the therapy listed here on the left. It's really to illustrate the minimum therapies that should be available at each level of care, and when appropriate for the patient, could be offered to them. For all levels of care, services should obviously be provided in the amounts, frequencies, and intensities appropriate to the objectives of the treatment plan and the individual patient's strengths, needs, abilities, and preferences. So we always need to keep that in mind. So when we look at this grid that includes all the levels of care and all the therapies possible, right, we need to be mindful that the three at the top here that are highlighted in red, so the individual and the group therapy and the use of motivational interviewing and motivational enhancement therapies and medication management, we see these interventions are available across all levels of care. And I think that's really important to note because that's really the foundation. These are the things that need to be available at all levels of care. And programs should always have the capacity to provide each of these modalities. So the individual, the group, the medication management, and the motivational enhancement strategies. Okay, so what we're doing now is we're breaking this out into outpatient, and then we're going to do residential in a minute here. So bear with me, and you can see that the therapies offered at each of these outpatient levels of care they're very similar. However, the intensity at which they are offered is what sets them apart from one another. Also, just want to remind folks that we made an effort to put page numbers in all of these slides so people can reference where to find the specific information in the ASAM text. So you'll see these, the page numbers across these slides. So again, the amounts of the hours offered in each level of care is what sets these levels of care apart from each other, in addition to a couple other things that we're going to be talking about. So obviously, level 1 offers less than 9 hours of skilled treatment services, and we're going to be talking about the definition of skilled treatment services in a minute. For patients with mental health conditions, the issues of psychiatric medications, mental health treatment, and their relationship to substance use and addictive disorders are all addressed as the need arises, so on an individual basis. Medical and psychiatric consult are available within 24 hours by phone or in person within a time frame that's appropriate to the individual, really tailored to the individual needs. Going on to 2.1, this is a level of care that offers a range, 9 to 19 hours of skilled treatment services. So again, it's not 9 hours, a minimum of 9 hours. It's a range, 9 to 19 hours. Intensive outpatient treatment differs from partial hospitalization, which we'll talk about in a minute, and that the intensity of clinical services that are directly available. Most IOP programs have less capacity to treat patients who have substantial unstable medical and psychiatric problems than do partial hospitalization programs. So then going on to the most intensive level of outpatient care, 2.5, partial hospitalization. This is a level of care where 20 or more hours a week of skilled treatment services are provided, so 20 or more hours a week. Partial programs typically have direct access to psychiatric, medical, and lab services and are more capable than an IOP program of supporting folks who have really multidimensional instability, but who don't require that 24-hour care. So again, just stopping here and mentioning the definition of skilled treatment services. So this is another very important definition I want folks to take a look at when they have an opportunity on page 429 of the ASAM text in that Appendix C. So this term skilled treatment services is a term that is used in the ASAM text to discuss outpatient levels of care and is defined as, and I'm going to just paraphrase here, it's defined as individual and group counseling, medication management, family therapy, educational groups, occupational and recreational therapy, and other therapies. Attendance at self-help and mutual help meetings such as AA or NA, volunteer activities, homework assignments involving watching videos or journaling, and workbooks do not represent skilled treatment services for the purpose of clinical service hours for each levels of care. So again, if you haven't had an opportunity to look at this definition and the others specifically in the back of the text, please take a moment to do so. They are really, really helpful, and they really help to understand the spirit of the ASAM criteria. So kind of transitioning now from outpatient to residential, and I'm going to explain these circles here in a minute. And again, I know this is a lot here on this slide. So it's interesting to note that when ASAM kind of goes on to the residential levels of care, they stop using this term skilled treatment services in the therapy section, and they instead pivot to a much more kind of comprehensive list of the kind of therapies that should be offered. So common themes across all the residential levels of care is involvement of the family. So that might not always be quote unquote family therapy, but it could also be a family support service. Also, the common thread of providing programming aimed at really helping folks develop skills necessary to reintegrate back into family and the community once they're transitioned to a lower level of care. So preparing people when they are ready to transition. Medication management, individual therapy, group therapy, and motivational enhancement strategies versus confrontational approaches remain central, right? So we noted that these were the kind of things, individual, group, motivational enhancement strategies, medication management, these are seen across all levels of care, and we see them obviously here in the residential levels of care. When we look at residential levels of care, we really make sense of the therapies offered when we understand the type of patient that really each level of care is designed to support. So with that in mind, I'm just going to take a few minutes here to stray slightly off the topic of therapies and just remind everyone by providing a very brief overview of each level of care and who it's really intended to treat. So in 3.1, a halfway house, group home, or supportive living environment, the patients best treated at this level of care often struggle with the application of recovery skills, self-efficacy, lack of connection to the community systems of work, education, and family. This is a 24-hour supportive setting. There is an allied professional who's available 24 hours a day. And this is maybe appropriate for patients who may not believe or acknowledge, or they may be struggling with this idea that they have a substance use disorder, and they may need to spend more time away from an environment that's not helpful or supportive to them. A major focus of this level of care is engagement and attracting people into continuing support and treatment. Therapies at this level of care are available at least 5 hours a week and are very much focused on assisting patients in building skills to facilitate that transition into autonomous functioning in the community. Structured activities that foster a sense of personal responsibility, respect and regard for others, punctuality, relapse prevention may be a common theme or a topic, healthy decision making and making the use of peer supports and community-based services for recovery is also a common theme in this level of care. Gaining employment, education, reintegration in the family, maybe learning about nutrition, other education around health topics would be appropriate. Moving on to 3.5, this is a level of care that assists individuals whose substance use is really so out of control or so severe that they need 24-hour supportive environment to initiate or continue the recovery process. Many patients in this level of care have significant social and psychological problems. The treatment community as a therapeutic agent is something that puts this level of care apart from others. Frequent defining characteristics of patients at this level of care include significant issues in the emotional, behavioral, and cognitive conditions, so dimension 3, and then the living environment, dimension 6. And so for this reason, an array of professional services should be employed as needed by each patient. Providing targeted education about relapse prevention, personal hygiene, physical health. A lot of the things that we talked about with 3.1 would also be appropriate here. It's important to note that in 3.1 and in 3.5, you can see that recovery support services are available. And I also just want to take a moment to point out the definition of this as well. The definition of recovery support services on page 427 of the text. And basically it states any services that are designed to initiate, support, and enhance recovery in the ASAM criteria, such as services considered dimension 6, so recovery environment, transportation, childcare, vocational and school counseling, peer supports, and legal services. So I just want to point that out, 3.1 and 3.5, that's a commonality between these two levels of care is the involvement of recovery support services. 3.7 is a level of care that is designed to meet the needs of patients who have functional limitations in dimensions 1, 2, and or 3. So limitations in dimensions 1, 2, and or 3, there is availability of 24-hour nursing and an MD or an NP or a PA. And they're working with the team and they are available as needed. So the hallmark of this level of care is a strong interdisciplinary team and the availability of support services that can accommodate withdrawal management and intensive inpatient treatment of addiction and any medical issues, maybe co-occurring issues that may be present. So 3.7 builds on all the therapies offered in 3.5 and includes therapies that address withdrawal management and biomedical and psychiatric issues. Obviously, having an SUD in addition to having a significant withdrawal or medical or psychiatric issue really complicates someone's ability to enter into and maintain recovery. Maybe there is an issue, maybe the individual believes that the issue is primarily SUD. They feel like that's really the problem, or they feel like the issue is primarily medical or psychiatric, not SUD. So how these multidimensional issues complicate one's efforts at recovery and improvement of health are really integral as interventions. Finally, level 4, our most intensive on the continuum of care. The principal focus of this is stabilization of the patient and preparation for a less intensive level of care. Treatment is provided 24 hours a day. There's a doctor available as needed. There's nurses available 24 hours a day. This is a level of care for patients whose acute biomedical, emotional, and behavioral and cognitive problems are so severe that they require primary medical and nursing care. It would make sense that in level 4, as you can see on the chart here, that supportive therapies, education groups, other therapies are not central. They're not a primary focus of this level of care. And it makes sense because this is a population that is quite unstable medically and psychiatrically. Therefore, it'd be probably pretty difficult to engage in those other interventions. Okay, so at this point, and I just want to remind folks that I know we're going through a lot today. This presentation will be available on the website for you to view at a later date. And if you had people on your team who weren't able to attend, they can also view the information on the slides at a later date on our ASAM alignment website, which a couple of QI staff kindly posted in the chat. So at this point in the presentation, we're going to be reviewing questions that we've received from providers on the topic or related to the topic of therapies. And I just want to thank those providers who did submit questions in the RA account leading up to this presentation. And I want to remind folks that if some of the answers that we go through today or that we provide complicate things for you, or you have additional questions, you may type those in the chat again. Or you can submit those questions to the ASAM account. Please, please, please don't hesitate to submit those questions. Our team is always available to do technical assistance. We've been doing a lot of technical assistance recently, and every single one of those technical assistance calls, I think, helps both parties, DDAP and the provider. So please don't hesitate to reach out. Just a reminder that if you choose to put a question in the chat, please be sure to put your email so we know how to get back to you. All right, so going into some of the questions. So this is a question about a previous recommendation that the department had given to encourage providers to employ 2-hour groups. So in April 2021, DDAP clarified that this was no longer a recommendation. A patient's daily clinical schedule, as we've been talking about for this entire presentation, it needs to be individualized and needs to factor in all the information found in the multidimensional assessment and the treatment plan. The example above of a patient who might have chronic pain issues or might be experiencing uncomfortable withdrawal symptoms. So individualizing treatment for this patient would include, among probably many other things, getting very creative and working with that interdisciplinary team and obviously working with the patient themselves to identify interventions that can help him or her reach their treatment goals but they're also mindful of limitations that the patient might have, like pain that makes it difficult for them to sit for this long period of time. So instead of forcing patients to fit into this one kind of size fits all treatment schedule, the treatment schedule and the clinical team should be flexible and willing to offer choices in programming and interventions. This means that the treatment plan that was developed in the beginning, it may at some point need to be amended as treatment progresses and maybe things become clearer or more information is available. And that is absolutely okay. Amending the treatment plan is okay. That's great. We just need to make sure that we're documenting any changes to the treatment plan as needed throughout the patient's chart so that we have that in their record. This next question is pretty straightforward. It asks, in order to meet the 16 hours of counseling services, could a nurse be utilized to do counseling to fill in any staffing gaps? And we did consult, obviously, with our licensing team on this. And yes, an RN can be used for counseling services. And they meet the qualifications in Chapter 704 for the position of counselor. They also must meet the minimum training outlined in the case management and clinical services manual in the core training section. So I think it's really important to always be mindful of that and to be checking there as well. And I'm going to turn over this question to Rebecca.
Great, thank you, Kathleen. So a common question we receive, and I think DDAP has received also, is do AA-NA meetings count towards the daily clinical service hours? And so we want to clarify that the NA and AA meetings or any other self-help or mutual support group that a person would attend is not considered a clinical service. A definition of skilled treatment services clearly states that attendance at self-help or mutual help meetings such as AA or NA volunteer activities, homework assignments involving watching videos, journaling, and workbooks do not represent skilled treatment services for the purpose of daily clinical service hours for each level of care. You can see the reference number page from the ASAM text for that. When we're looking at daily clinical services, that means that someone is employed by your agency and providing a service to only people receiving services at your agency. So this could be in the form of individual, group, or family therapy, psychoeducational groups, relapse prevention, or any other formalized service that your agency staff provide. Progress notes reflect clinical service hours, and all progress notes relate back to the individual's treatment plan. Programming might include self-help meeting recommendations or attendance, but these meetings do not count as part of the treatment services provided at your agency. Okay, next slide, please. And, oh, Kathleen, this one is yours.
Yes, got it. Thank you. All right, moving on to the next question. Are 3.5 and 3.7 providers required to provide 6 to 8 hours of daily clinical services? So I included page references on the response that I have on the slide here. So the requirement at this level of care is that daily clinical services are provided, meaning that clinical services, and I'm talking about the therapies that we just talked about in the previous slides and many other elements, are offered 7 days a week. So this includes weekends. That's obviously very important. So daily clinical services is the requirement. So DDAP recommends that clinical services be offered 6 to 8 hours daily in accordance, obviously, with individual treatment plans, but there's no required number of hours. So again, we just need to be mindful that programs should have the capacity to provide the therapies noted in the text, and again, that we just went through for each level of care. And each day should include activities designed to meet the needs of the patients as defined in their individual treatment plans and as noted in their multidimensional assessment. Somebody should be able to come into that program, meaning like an auditor or an external party, and they should be able to see, what the patients did that day, and they should be able to link that directly to what is noted in their multidimensional assessment in their treatment plan. It should be very, very clear. Okay, so for slide number 7, here we go. I am seeking clarity about what counts towards the 6 to 8 hours. Again, this is this is pretty much the similar question that we just had. What counts toward the 6 to 8 hours, and do medication times count towards that time? And yes, so again, when we look at the therapy section of the text, we can see that medication times is included. And I have a direct quote here from page 252, monitoring of the patient's adherence in taking any prescribed medications and or permitted over-the-counter medications or supplements, along with several other interventions. That is directly listed in that therapy section for 3.5. But I did just want to take an opportunity. I'm going to stray just a little bit here, so bear with me. I did just want to take an opportunity to go beyond 3.5 for a second and to point out again that across all levels of care, pharmacotherapy and med management is listed as a therapy that providers should have the capacity to provide and or coordinate. So this is something that is uniform no matter what level of care you're in for ASAM. And I think that really just speaks to the importance of the integration of medication management and pharmacotherapy and MAT for individuals. Again, we're not talking about just MAT, we're talking about psychiatric medications, obviously physical health medications. But I mean, it is extremely clear that this is something that providers must have the capacity to provide and or coordinate across all levels of care. So absolutely, yes, this is counted as a therapy for sure. Okay, turning it over to Rebecca for this one.
Thank you. So are chores considered a part of daily clinical services? And so daily clinical services entail a formal service offered by a staff member employed by the agency to people receiving services at your agency. So when we're looking at the idea of chores, you're looking at your staff and what formal service is your staff offering during the completion of chores. And we're going to jump to the third bullet point, direct or indirect observation or supervision of activities of daily living or ADL is not considered a clinical service. So chores themselves, although they are important as a part of recovery, are not a daily clinical service. They're an activity that someone may need to do in their recovery. They may need to learn how to do chores, but the actual completion of chores itself is not a daily clinical service. Daily clinical services require a progress note that relates back to their treatment plan. If you want to do a psychoeducational group that looks at chores and how to complete them and the importance of doing chores, that might be considered a daily clinical service or part of a clinical service offered with appropriate documentation, once again, tying it back to that individual's treatment plan. But chores themselves, once again, are not a clinical service, as the staff member employed by the agency is not offering a formal service during the completion of chores. Okay. Next slide, please. And when we're looking at the next question, which is how does case management fit into treatment models if it's not listed as a clinical service? And so we want to make sure that all patients are being assessed for case management needs. Case management, although not listed in ASAM as an intervention under the various therapies section, is an extremely important adjunct to treatment and ensures patients receive the level of care coordination needed to move seamlessly along the continuum of care and to be prepared for discharge and transfer. Case management is noted in the Case Management and Clinical Services Manual as a separate and distinct service from therapy session and can be provided by the treatment provider or through the SCA and should be based on the individual's needs. When we're looking at case management, not every individual at your agency may need case management services. And so when you're doing that assessment, you're looking for what does this individual need? How can case management help? And who is the appropriate case manager to do some of these things? Sometimes it might be your agency staff that are most appropriate to do the case management needs, but sometimes it might be the SCA because they're going to be able to follow that person throughout the continuum of care. So something to keep in mind as you are looking at case management and those referrals is looking at what does this person need and how long might they stay in your treatment facility and who's going to be the best person to meet the needs of that individual. Kathleen, was there anything else that you wanted to say about case management?
No, that you covered everything. Thank you. Right. Okay, and this is the last question here. So the question is, our program is worried we won't be able to meet the 1:15 IOP ratio due to staff turnover and shortage. Can you speak to this? So in addition to the information that we have on this slide here, the 3 bullet points, I also just want to remind providers that the central tenet of IOP level of care is that range, again, of 9 to 19 hours. So it's not 9 hours, it's a range of 9 to 19 hours. Of skilled treatment services, that definition that we covered earlier on in the presentation today. So a range of 9 to 19 hours. IOP providers should be able to provide up to 19 hours of skilled treatment services if indicated. So if that individual patient needs that as identified in their multidimensional assessment and their treatment plan and other factors. So offering an appropriate range of evidence-based therapies, which are listed on page 199 of the ASAM text, is also a central tenet of this level of care. You know, in addition to the therapies offered the 9 to 19 hours, there obviously needs to be the appropriate staffing, documentation, and support systems as noted throughout the ASAM text. So the 1:15 ratio is a recommendation and not a requirement. And providers obviously always still need to be working or operating within the PA regulations. And I just cannot stress enough the importance of being able to provide the range of 9 to 19 hours. I'm not saying everybody needs to have 19 hours, but providers need to have the ability to provide up to 19 hours of skilled treatment services weekly in an IOP setting. So that is the end of our slides today. I'm looking at the time, it's 10:42, so we are ahead of schedule. So I just want to take the opportunity right now to say thank you for everybody who was able to join the call today. We really appreciate you doing that, and the recording of this call will be available at a later date on the ASAM alignment website, along with the slides that we went through today. I want to say thank you so much to Rebecca Sedlock for presenting with me today. I just really appreciate that coordination with CCBH, and thank you so much, Rebecca. And in terms of the topic for the next call in the beginning of February, we do not have that decided yet. That will be announced shortly. But since we do have a little bit of time today, if you have any recommendations or suggestions for a topic that would be helpful for us to present, please don't hesitate to put that into the chat. We would really, really appreciate that. And we will be communicating the topic that we will be presenting on via email. So just want to say thank you again so much for joining us today. We hope to see you in early February for our next ASAM monthly TA call. And I will be keeping the chat on and the meeting on in case people have questions that come up for the remainder of the time. So I will stay on here until 11 o'clock. Happy New Year to everybody, and thank you so much for coming today.